We live in a consumer-oriented age. We're discriminating shoppers, from the toothpaste we use, to the schools our children attend, to the quality of health care we receive. Nowhere is this more apparent than in the relationship we have with our physicians. Words like partnership, informed consent, and patient-centered care are replacing the notion that our physicians have all the answers. Consider our assumption that blood transfusion equals saving a life. Without question, we've understood that giving and receiving blood is the gold standard in surgical practice. It's held cultural and historical significance for generations. This deeply ingrained and widely accepted medical procedure is now being challenged. The nation's declining blood supply, issues surrounding the storage of blood, concern about recovery time and the risk of infection, as well as patients' personal and religious convictions, have caused specialists worldwide to question the status quo and commit to new and more effective alternatives to donor blood. Patient blood management is on the forefront of this movement. Increasing numbers of highly respected surgeons worldwide believe it is healthier, safer, and less costly for their patients. Dr. Pierre Tibby is the Medical Director of Cardiothoracic Surgery at Yavapai Regional Medical Center in Prescott, Arizona. Dr. Tibby is bringing awareness of the benefits of patient blood management to physicians worldwide. Dr. Tibby, what is patient blood management?
Well, Joanne, patient blood management is the idea of taking a patient and treating him in the best possible way, trying to understand that blood sometimes is extremely essential, but sometimes is not essential. And to tell you the truth, we are discovering that blood administration is significantly overused in this country as well as around the world. Unfortunately, over the years, we've been encultured to think that if a patient's got a low blood count, give them a unit of blood. In fact, it's amazing to know that normal red cell, hematocrit, red cell count, is in the low 40 range. We have reflexively given a unit of blood when it gets to 30. Do you know when that level of 30 was decided to be? 1947. 60 years. And you really cannot find any recent good data that is collected in a prospective, blinded fashion that shows that 30 is the level at which a physician should transfuse a unit of blood. Nevertheless, that is our reflexive response in many cases.
Why is there so little regulation and oversight with this particular procedure compared to virtually any other medical procedure you can undergo?
During the world wars in the 20th century, we have been encultured as a nation, not only lay people, but physicians, that blood is good, that blood is essential to life. And it's just amazing that we transfuse blood the same way we did 60 years ago, or until recently. That we've come so far in so many other treatments, whether it be cancer, whether it be robotic surgery, whether it be anything. But blood transfusion is done in almost exactly the same fashion. Obviously, there are more precautions, etc. There's slightly more regulation, but nowhere close to where we should be. And I think we all are, lay people, physicians, regulatory agencies, are waking up to the fact that blood may not be as good as we once thought.
Why is donor blood inferior to a patient's own blood?
One, it's stored blood. It's not fresh blood. It's missing chemicals and properties that fresh blood or the patient's own blood has. It has reaction. The body reacts to someone else's blood in some ways that we know and some ways that we don't know. It's a possibility to be a carrier of bacterial or viral or even parasitic infections. There are risks in giving blood that are simply not found in patients' own blood. Patients have higher morbidity and mortality, increased length of stays if they've received someone else's blood. Patients, like I said, who are compared to similar patients, those that received blood versus those that didn't receive blood, they have less pulmonary complications, less kidney complications, less coronary heart complications, lower length of stay, decreased mortality.
What are the long-term side effects of transfused blood? Do we know them all?
The fact that we are giving a mini transplant and there are a significant amount of immunological response, and how long or abbreviated that response is, we don't know. We do know that patients who get more transfusions are more likely to get cancer. Blood conservation is not a procedure. It's an overall thought process on how to deal with patients with one of the primary concerns to prevent a transfusion. For example, when a patient comes to the office and we are contemplating open heart surgery, in addition to looking at the specifics of the case, his arteries, his valves, etc., I pay close attention to what his blood count is, what drugs he's on. Is he on drugs that's going to cause him to bleed, such as Plavix or Coumadin? So it's careful assessment of the patient. If their blood count is low, we can treat them with drugs that will boost their own bone marrow to produce blood, extra blood, so that we have a greater safety net. So it starts from the moment I set eyes on the patient. Obviously, the most important thing is meticulous surgical technique. Additionally, there are many drugs and techniques and substances that we use to prevent bleeding while in surgery. Particular to open heart surgery, there are things that we do, such as we drain off a couple of units of the blood and hold it there and give it after the operation. Now you're going to ask me, well, it's the same blood, what's the difference? The reason is because in many open heart procedures, patients are put on a heart-lung machine. This is a machine that will take over the function of the heart and lungs while we stop the heart, open the heart, and work in it. Well, as this blood goes through the machine, a lot of things happen. And some of those things are we dilute or eliminate the factors which help the blood to clot. Whereas if we take a couple of units off before the operation, we circulate a lower blood volume during the operation, and then we give the patient back his own blood. That is fresh blood that has not been adulterated or harmed by the heart-lung machine. We have some special circuits that have coating that decreases the injury to the blood cells. We have substances that we can put on the heart or other organs where there's what we call diffuse oozing that will prevent further oozing. I mean, there are probably about 25 things that I utilize to prevent giving a unit of blood.
Bringing back to the cath lab, the stress test was abnormal. And as you can see, he still has a chronic occlusion of the right coronary artery.
YRMC cardiologist George Risk has fully incorporated patient blood management into his practice.
The whole program is common sense. It really is common sense and good preparation. And that's pre-op and with the meticulous skill of the surgeon and post-op. So it really is not, there's not any highly computerized machines that are helping you save or produce blood during the procedure. It's a combination of just being prepared well and common sense.
The quality of stored blood is an important consideration. As soon as blood is drawn from a donor, its biochemical makeup begins to change in a number of ways. This is referred to as storage lesion.
Storage lesion is two-pronged. The first is the association with increased risk of infection that's been noted by a number of studies. Substances are building up in the stored blood that affect our immune system, our ability to fight infection. The studies that have shown increased risk of infection will cite increased rates of pneumonia, of wound infections, of other complications as well following transfusion of stored blood. The other is a concern about the delivery of oxygen of stored blood. Two things happen to stored blood that we know about. One is that the cells become more rigid, they're less flexible. And to deliver oxygen in the microcirculation down at the capillary level where oxygen is exchanged into the tissue, the cells have to be quite flexible to actually fit through the narrow capillaries. If they become rigid, they will not, and you worry about a sludging effect of the cells as they reach the microcirculation. They actually also impact on the lining of the microcirculation. The concern, one of the substances that's noted, nitric oxide, is diminished in the stored red cells. And as that substance is picked up, scavenged basically is the theory that it's scavenged off the endothelial cells by these stored red cells, that it will reduce the ability of the microcirculation to dilate in response to need for oxygen.
So let's think about this. We give blood. The primary reason to give blood is to treat shock. Shock is in any organ that is not getting enough blood. Whereas with stored blood, instead of treating shock, we may be making it worse because we're holding on to the oxygen, we're constricting the vessels, we're making the red cells less deformable, and we're possibly causing a clotting cascade. Everything that we don't want to do, because stored blood is not fresh blood. And the fact is that most hospitals, the blood is stored from 4 to 6 weeks. You might be getting very old blood.
Dale Black is the coordinator of the Yavapai Regional Medical Center Patient Blood Management Program.
In the late 1940s and early 50s, very few understood that there were negative things associated with blood. And that's not fault finding, that's just the way that it was. What was perhaps viewed then as heroic interventions that saved lives, we have come to realize over the decades, perhaps now is an overutilized technique and procedure with many adverse effects and outcomes. But you ask the question, why do we continue to see it? It's basically the enculturization that applies to doctors and physicians too. It's the way they were trained. I mean, we're human beings and we all resist change. And if we were taught this in medical school, this is absolutely what we're going to be practicing. And so this resistance to change, which is a human behavior, is what we have seen. And yet, in reality, as clinicians and academics learn more and more about this, patient blood management is coming into its own as the gold standard of care.
There are some patients that choose it because of ethical concerns and some patients because of religious beliefs. So that's how the program initially got started. Patients with religious beliefs began asking, was there a way to do the surgery without accepting blood? So those are the patients that we initially started working with, and we saw that they did well, and then we started to incorporate other ideas to help them through the surgery, and then we decided this may be something that we should offer all of our patients.
When I first went in with my first appointment with Dr. Tibby, I was very much impressed when we sit down and started talking and letting him know who I was, and that because of my faith, I would not take whole blood, and he was just very calm. And then he says, "Oh, well, then you probably have one of these cards that, you probably carry in your billfold." And I said, "Yes, I do." And he had it right there on his computer, and he had a lot of our literature. So he understood our beliefs as well, which very, very impressed me. But obviously he has those because, he knows the benefit to having surgery without whole blood. Yeah, I really was. I was very impressed with that.
Well, as you can imagine, education is the key. And as patients become aware of the better outcomes that are being experienced by those who don't receive blood products, tying that into some of the risks and dangers associated with blood transfusions, more and more patients are asking that they be given consideration for this kind of program, that they want to avoid the use of allogeneic blood and blood products.
In recent years, the Society of Thoracic Surgeons released and updated their patient blood management guidelines. Physicians, clinicians, surgeons, and consumers worldwide can visit their website to view evidence-based recommendations.
We are looking at this as a physician nation, and we think that it's extremely important. This is developing very quickly, that more and more institutions are looking very, very carefully at their blood utilization and how they can improve their utilization for many reasons. For the reasons of better patient care, for the reasons of lower cost, for the reasons of being able to offer these services to patients who refuse blood. I believe that basically Yavapai Regional Medical Center is a poster child for patient blood management, and if it can be done in a community hospital such as Yavapai Regional Medical Center, it could be done anywhere. You know, sometimes we spend millions of dollars on high technology with very little result and sometimes a negative impact. Here we're spending few dollars, in fact making dollars, improving care, and in a sense, it's not very high tech, but it's at the cutting edge.
Yavapai Regional Medical Center continues its cutting-edge leadership. Dr. Tibby travels worldwide to speak to physicians and other professional groups about patient blood management. And recently, YRMC hosted 30 directors of anesthesiology from China for a symposium on patient blood management. They witnessed blood conservation techniques live during an open-heart surgery performed by Dr. Tibby.